The importance of screening guidelines, a case of colorectal adenocarcinoma presenting as extensive metastatic pulmonary disease. My name is Isha Balbanani, and I'm a resident at Mount Sinai Medical Center in the Department of Internal Medicine in Miami Beach, Florida. Starting with the introduction. Patients with colorectal cancer who have either non-metastatic disease or oligometastatic disease, meaning metastatic disease to only one site other than the primary, are potential curable candidates. About 20% of the patients with colorectal cancer have metastatic spread at the time of diagnosis, and these are called synchronous metastases. Metastases to the liver and the lung are the most common. Rates of colorectal cancer have declined among patients of 65 years or older, largely due to increased screening efforts. Most pulmonary metastases from colorectal cancer are either solitary, appear in the periphery, or occur as large consolidated cannonballs on imaging. Moving on to the case presentation. We present a 67-year-old male with a medical history of non-insulin-dependent diabetes who presented to the hospital after he was found to be hypoxic at his primary care physician's office earlier in the day. Per patient, he had been experiencing dyspneic insertion for the past 1 week, and he also admitted to 3 months of intermittent left-sided abdominal pain with associated constipation and diarrhea. He denied other symptoms such as melena, hematochezia, or bleeding elsewhere. Of note, patient is a daily tobacco smoker and a current smoker and admits to a 30-pack year history. He has not had recommended screening tests performed, such as low-dose CT scan of his lungs or screening colonoscopies. Review of systems was positive for unintentional weight loss of 17 pounds in 2 months and generalized fatigue. Vital signs on admission were significant for tachycardia up to 110 beats per minute and hypoxia with patient saturation of 90% on room air that improved to 96% with 2 liters nasal cannula oxygen supplementation. EKG showed sinus tachycardia. His hemoglobin was 10 on admission, while his baseline hemoglobin from 6 months prior, based on chart review, was 14. Platelets were reactively elevated at 775,000, and CEA was high at 140. Chest X-ray demonstrated multiple nodular and consolidative airspace opacities, as seen in figures 1 and 2. Figure 1 shows a chest X-ray in a PA view, and figure 2 shows chest X-ray in left lateral view. Both demonstrate aforementioned nodular and consolidative airspace opacities that are innumerable in nature and randomly distributed. CT chest with IV contrast, as seen in figures 3 and 4 in the lung window view, demonstrate the same innumerable randomly distributed nodules. CT abdomen and pelvis with IV contrast was also performed that showed a 2.7 centimeter focus of wall thickening and narrowing in the sigmoid colon concerning for malignant mass, alongside a mass in the liver concerning for metastatic lesion. Biopsy was performed of one of the lung nodules, and pathology revealed a colorectal adenocarcinoma with cells positive for CK20 and negative for CK7. Patient opted to be discharged from the hospital to follow up with oncology as an outpatient to start treatment. Finally, for our discussion. For patients with localized colorectal cancer or liver-only or lung-only metastatic disease as an oligometastatic disease, surgical resection is the only potential curative treatment. The most important prognostic factor in colorectal cancer is the pathological state at presentation and extent of widespread disease. Fewer of 20% of patients with metastatic colorectal cancer treated with chemotherapy alone are still alive at 5 years. In comparison, the 5-year survival rate for all stages, except non-oligometastatic stage 4 disease, is greater than 80%. Although the patient had frequent outpatient follow-up, he never underwent his recommended screening tests. If he had underwent screening tests and colorectal cancer was caught earlier, his disease could have been prevented and treated with curative intent. In addition to this patient's extensive metastatic pulmonary disease, the pattern of his disease was unique in that the nodules were randomly distributed, innumerable, and small. Palliative systemic therapy is reserved for non-surgical colorectal candidates, as in our patient's case. Such treatment of metastatic colorectal cancer is evolving, and management is increasingly being driven by individual tumor biology and gene expression analysis. That concludes our presentation. Thank you for your consideration.